I'm Norman Swan. Welcome to this programme, A is for Asthma, Managing Asthma in Primary School Children. Back to school asthma is a common problem in Australia, with a spike in asthma-related hospital visits for school-aged children occurring in the first few weeks after each school holiday. With 1 in 9 school-aged children in Australia being affected by asthma, the highest annual peak is in February as students return from the long summer break and are exposed, presumably, to a cocktail of viruses. Asthma in children differs from asthma in adults in clinically important aspects, which includes the patterns of symptoms, anatomical factors and recommended treatment. And that's what the programme's about tonight. And you'll find that some popular treatments are being given inappropriately. You'll find a number of useful resources, as always, available on the Rural Health Education Foundation's website, rhef.com.au. Now let's meet our panel. Adam Jaffe is the Director of Respiratory Medicine at Sydney Children's Hospital in Randwick. He chairs the Aiming for Asthma Improvement in Children programme in South East Sydney and Illawarra Area Health Service. Welcome, Adam.
Thanks for having me.
Kerry Hancock is a general practitioner in Adelaide. She's a founding member of the National Asthma Council's GP's Asthma Group and a medical advisor to the Asthma Foundation of South Australia. Welcome, Kerry.
Good evening.
Tracy Marshall is a clinical nurse consultant in asthma education in the Department of Respiratory Medicine at the Children's Hospital Westmead. Welcome, Tracy.
Thank you very much, Norman.
Tony Riley is a community pharmacist in Bendigo in Victoria, and she's a founding member of the National Asthma Council's Pharmacists Advisory Group. Welcome, Tony.
Thanks, Norman.
And another Tony for you, Tony Healy, who's the National Coordinator of the Asthma Friendly Schools programme based in Adelaide. Welcome.
Good evening, Norman.
And welcome to you all. So are the schools all ready for this surge in asthma cases as we speak?
The Asthma Friendly Schools program has penetrated into about 85% of the schools around Australia, so they are informed about the fact that there is a back to school asthma spike that occurs at the beginning of each year. They have that information and those schools are well prepared to deal with asthma exacerbations when they do occur.
Do you see them in pharmacies?
Yes, we do,
flock
Norman.
in?
I think at the beginning of each school term there's always a sudden increase in need for especially reliever medication, so we do see an increased volume of prescriptions at that time, but I think probably, as we'll talk about later on, one of the things we also do see is an increase in scripts for other things like antibiotics in children.
So is this a failure of asthma action plans, Tracy?
Well, it's certainly a possibility. I mean, we know in this country that we don't have the percentage of asthma action plans as health professionals that we would like to see. So certainly I think that would certainly aid in helping for parents to manage these asthma episodes at home and definitely for at schools as well.
And whilst it sounds bureaucratically neat to have an asthma action plan,
Yep.
they actually do in children make a difference, do they?
Absolutely, there's evidence that shows that they do make a difference. But there are many factors in terms of how they're written and the types of medications that are on them that can have an effect on them. So it's important to have a good asthma action plan.
Kerry, what about general practice? The surge hits you?
We see the surge, okay. I think it comes from a number of reasons, that people become complacent over that holiday break. All the kids go back to school exposed to the viruses, children who should be on preventers, maybe not taking their preventers.
But your group's done some work on this.
That's right. Norman's, Bill Rawlinson's Professor of Virology at Prince of Wales Hospital and looked at the sort of bugs that are around in February in children with asthma and found that there's a huge number of children with rhinovirus in the nose. So it's likely that this peak is related to this mingling at schools between teachers and students and passing all these bugs around, which is likely to be a major contributor.
Now, one of the themes tonight is that it's the usual stuff with kids, that kids aren't little adults, but it's particularly true in asthma. I mean, what my understanding is that it's actually a different disease in children from adults.
Well, you're absolutely right. I think the problem with the pediatrics and particularly the under 5-year-olds is that what we're learning is that there are different types of wheezy children, different phenotypes that are emerging. If you speak to an adult physician, they think we're crazy. They said they know exactly what an asthmatic looks like. They're usually atopic. They wheeze a lot. There's a strong family history, but certainly in the under 5s, there's a whole variety of children. Some who only get wheezy with viruses. Some children are wheezy because their parents, their mothers have smoked antenatally, and therefore, particularly if you're a boy, have smaller airways. But then there's that classic group who are atopic or got a strong family history, who go on to get the classic asthma that we're all aware of.
So wheezy bronchitis is returned as a diagnosis?
Yes, it has. It went out of favour for a while. In fact, work in the 70s suggested that 1.3 or so American children had wheezy bronchitis. That went out of fashion. They said, now we've termed it asthma, but it's come back now. And I think it's an attempt for us to understand the pathophysiology, what's going on, what's causing this. And in fact, there was a plea by the Lancet, an editorial a few years back, to abandon the concept of asthma altogether. As Fernando Martinez says, in the 19th century, we used to treat fever. Now that we know that there's a cause for fever, and that perhaps we shouldn't be terming asthma in children as one disease, we should be dismantling it, which is what we're trying.
Not all that wheezes.
Correct.
Are you finding that scripts for combination therapies marching out the door in pharmacies for children?
I guess there certainly has been an increase in the use of combination therapy in children, and as we all know, that's not actually recommended in younger children. So there is a concern about that, but I'm sure that Kerry and Adam are far more qualified to speak about that than I am.
I mean, that's what I was talking about earlier when I said it's inappropriate. We're seeing really a lot of doctors thinking that what they've been taught about adults applies to children, and it is with serious consequences.
I think there's always a temptation in medicine, and especially in general practice, to transpose what we have learnt in adults to children, and nothing could be further than truth in the management of asthma in children. But
it's also been a huge marketing push.
There probably is, yeah. But I think we have guidelines for appropriate management, pharmacotherapy management in children, and we have the evidence base behind those guidelines. We don't have the evidence base behind the use of long-acting beta-2 agonists in children.
So what's the problem, Adam? What happens when you put a child on combination therapy when it's not necessary?
Well, I think just to reiterate what Kerry said is that we did some work looking at UK prescribing, and there's some work to come out of Canberra showing that the prescribing of combination therapy, including long-acting beta agonists, is skyrocketing. So no one's listening to the guidelines for a start. That's clearly obvious. And I don't think people are aware of the problems that the long-acting beta agonists can cause, particularly
even in combination with steroids.
Even in combination with steroids. Certainly the evidence originally looking at long-acting beta agonists in the States, when there was an increased risk of death in adults, particularly African Americans, and that there was concern about using long-acting beta agonists without steroids, so no one would use it without steroids now. But
in fact, they've just been taken off the market in America.
Correct. And therefore, even with inhaled steroids, there's a concern that they're causing tachyphylaxis. In other words, children are not able to respond even to beta agonists, so salbutamol treatment. And we've certainly seen that in our clinic, where children have come in very fine athletes who are getting short of breath. They're on long-acting beta agonist combination therapy, and take a long time to recover from challenges. And when we take them off long-acting beta agonists and the combination, and treat them with inhaled steroid, then they get better. And I think people have to be aware that the use of long-acting beta agonists is potentially extremely dangerous. And
even inhaled corticosteroids don't necessarily work as well, particularly in the young child, as in the older child.
Well, certainly, if used correctly, they're an extremely useful and good drug. There are obviously other potential alternatives to inhaled steroids, such as leukotriene receptor antagonists. So they do exist, but if used correctly, inhaled steroids is a very good first-line preventer.
Now, leukotriene receptor antagonists are sort of considered second line here, but you actually disagree with that.
Yes, it's interesting, and if you look at the Australian, the National Asthma Council guidelines, then montelukast is a potential second line with inhaled steroids. But if you look at the other guidelines, for example, the European guidelines, the Scottish guidelines, and the American guidelines, that the second step is inhaled steroids, and montelukast comes later on. So the problem, I think, in Australia is driven by the PBS and the authority prescribing, that you cannot prescribe montelukast unless it's a single line preventer, and therefore it's going to cost a patient 3 times as much if they can't get it on authority. And therefore these guidelines and the PBS have actually, I suspect, driven the prescribing practices in this country.
This is relevant to one of the questions, so I might bring it in now. It's from Marissa Pilla in North Queensland, far North Queensland. What's best used in young children cortisol-based inhalers or your Intal or Atrovent? Also, is it safe to use high doses in children long term? I've seen 2-year-olds on very high doses when the asthma is not controlled in any other way. I have concerns. Any comments? Kerry?
I think there are concerns about when you're needing to use high-dose inhaled corticosteroid in a child of any age, let alone a 2-year-old. Certainly you'd want to address whether the diagnosis is right. I mean, are we dealing with asthma? Are we dealing with something else that's causing these asthma-type symptoms in this young child?
And adjuvant ipratropium is really a reliever, not a treatment.
Reliever. So I'm not quite sure whether the question is around ongoing preventive therapy or for acute management. But even the role of Atrovent in
It's a no-no
acute.
these days, isn't it? Tony, Atrovent, isn't it considered...
Certainly not first-line treatment when you're considering a reliever medication, that's for sure. It's very much down the pathway and used quite infrequently now.
And what about chromoglycate? Given that you're down a bit on steroids, in the old days we seem to get a bit of service out of it in children. The adult physicians were always down on it.
Yes. Well, there's certainly a role in exercise-induced asthma. So it's not used as widely. There are a few people left to still use it. I will use it in a certain subgroup of children with exercise-induced asthma. So there's a role, albeit in a specific population.
And what about Indigenous children? Are we talking about a different situation here? I mean, in the epidemiology of childhood asthma in Australia?
Well, if you look at the publication of asthma in Australia, who've looked at the prevalence of asthma amongst different groups, certainly, like all respiratory health in Indigenous children, it's worse off. Indigenous children have more asthma, a high risk of hospitalisation and mortality, and that may be related to a whole heap of factors, but particularly smoking. I mean, smoking in the Indigenous communities is twice as prevalent as in non-Indigenous communities, and I think that's a very important topic to address in all communities.
What's the School Friendlies program that you've got, Tony?
The Asthma Friendly Schools program provides a framework to schools across Australia to instigate recognise best management practices to help prevent asthma and to manage any asthma exacerbations. So there's a staff training package that's delivered to teachers around Australia. There's information provided to the parents and community about their connectivity with the asthma foundations so they can get individual advice. And we also penetrate the school curriculum through the use of resources. We have DVDs. The first one is provided to primary schools, and on our website we have backup lesson plans for junior, middle and upper primary young people. And for the secondary component, we have the Running Short DVD that was developed in consultation with the Adolescent Asthma Action program. The work of Dr. Smitterstar is well known in schools across Australia, and I'd like to acknowledge her for the use of this DVD within our program. That provides all young people in asthma-friendly schools across Australia with the chance to have a bit of an understanding of the condition, so that if it's not them that has asthma, they can provide some support to friends or family in that regard.
And what's the two-way communication like? I mean, do you rely on the child and the child's parents telling you they've got asthma, or is there a communication with the general practitioner?
The parents are the go-between between the practitioner and the school, and the key critical component of that is the written asthma action plan that gives us the advice that schools need to be able to react on an individual basis.
Adam, diagnosis. How to make the diagnosis in general practice? What's your view on this? And I'll come to Kerry in a moment.
It's not easy in the under fives. Let's pick the easy one first. So the child that we all recognise as having undisputed asthma is the child who's atopic, who has perhaps rhinitis, eczema, perhaps a food allergy, strong family history, will have doctor-diagnosed wheeze, and that's the child that we all accept as having asthma. The child under 5 who wheezes with various triggers, very difficult, and I'm glad I'm not a GP.
So, Kerry, what's the role of spirometry? People like Adam say, that's like a blood pressure machine. It should be done on every child with your suspect of a problem.
Well, we can't do it on every child. I mean, children have to be a certain age before we can effectively undertake spirometry on them. So maybe from around about the age of 8, certainly an attempt should be made at doing spirometry, and that's going to go a reasonable way to helping confirm that diagnosis in children where you've got a suspicious history.
And so you would look for reversibility?
Look for reversibility, but also bearing in mind that between the episodes of asthma, children may have normal spirometry.
And what about provocation tests in general practice?
It's a matter of whether they're accessible. A lot of GPs, maybe in remote areas and rural areas, may not be able to access provocation testing, but certainly if children could be sent into provincial towns and major cities, some provocation testings are available in some of the large respiratory function labs or at the tertiary hospitals.
And skin testing, particularly in country towns, I mean, you can often get that done, but does it make a difference to the diagnosis?
Yes, no, I think it's a very important test to do because if a child's atopic and wheezing, then I think that will point you towards the classical phenotype of asthma. So it's an important investigation to do.
And the predictors of more severe asthma in the years to come are things like eczema and food allergies.
That's right. It's the atopic phenotype that predicts you to have recurrent wheezing throughout your childhood.
And of course, smoking is important here.
Smoking is crucial to address because
not to treat it, but
no, absolutely. I mean, it's antenatally, if you smoke, you have smaller airways. Passive smoking, it has to be addressed at all times. Parents who say, I always smoke outside, never in the house, doctor. If you measure cotinine in saliva, it's evidence of tobacco exposure. And we did some work in the East End of London which looked at difficult asthmatics, those children on 800 micrograms equivalent budesonide a day, and smoking in the family was the strongest predictor of difficult to control asthma.
I should have done this at the beginning. We should get given that we're talking about a strongly pharmaceutical area, we should get a declaration of any conflicts of interest here that you wish to do. Tony, you...
No conflicts of interest? No.
Not for me either.
No.
I sit on advisory boards for AstraZeneca and GSK.
Right, so that's Symbicort and Serotype. So that we know who talks, yeah.
And I've been paid by honorarium to give various talks by GSK and AstraZeneca, and currently sit on MSD advisory board to make Singulair.
Right.
And, unfortunately, that's all.
Okay, so if you start peddling things, we know where you're coming from. Tell me about the classification here, just how GPs should be thinking about asthma in terms of severity.
It's really important for GPs to look at the pattern of asthma in order to make that classification, because once they've made the classification, then the guidelines for pharmacotherapy sort of fall into place. So bearing in mind that most of the children that we're going to see in our general practices are going to have infrequent intermittent asthma. So 75% of children will have infrequent intermittent asthma. Then 20% will have more frequent episodes of their asthma, but will still be intermittent. So those episodes may be every sort of 6 to 8 weeks, or even a little bit shorter space. And then you have a group of children, just a very small group of children, 5%, who have persistent asthma. So these are the children who are going to have symptoms once a week, a few times a week, or maybe daily. So just a very small amount. And depending on that classification will depend on what pharmacotherapies we use for those children.
So Tracy, do you think that education at the 75% end, where it's just occasional asthma once or twice a year, do you think education matters in those children, or it's so infrequent that it's not important?
Oh no, it's important across the board, because for those group of children, it could be 6 months in between their episodes. It could be longer, and especially as their age group changes, they can require more Ventolin when they get older, or any other reliever type of medication. So yeah, education across the board, whether you have an infrequent type of asthma or whether you have a persistent, is very important.
Because it puts in a foundation for the future.
Absolutely, and it's about self-management for the children, especially as they move into primary school and into high school, is to allow mum and dad or the carers for the family to have a greater understanding of what asthma is and how to manage it. So regardless of where they are in their classification, education goes hand in hand with management.
Tony, do you find many people confused when they come into the pharmacy?
Probably less these days than in previous days, but yeah, people do get confused about which inhaler they're meant to use for which particular situation. Is this my reliever medication? Is this my preventer medication? And I think one of the things that's really important to remember, when we're talking about rural health here, not all areas have the plethora of health professionals available. Maybe in some regions you've just got the GP and the pharmacist. So the team approach is really important, and that certainly I think carries through with the education side of it. You know, the pharmacist has the opportunity to have another shot at, you know, we might actually see the child in the pharmacy. We can actually run through how they use their medication, which is their preventer, which is their reliever, those kind of things.
I've got another question here. We've got some case studies for you tonight, but there's one question here that's probably relevant to bring up here. This is actually from Marissa Pillar again in Far North Queensland. I understand the importance of use of preventers, especially the new use of Symbicort. I have to say, Symbicort's not approved for use in children, is that right?
No, it's not approved for use.
However, what is the true outcome on growth? Is it affected at the end of the growth period, especially if there's need of a nasal cortisol spray, which indeed there often is, because as we've shown in this program, allergic rhinitis is a significant predictor of severity. So what's the story with growth here?
No, I think it raises a very, very important point. So if we talk about nasal steroids to start with, a lot of people believe that asthma is a disease of the nose, and there's a lot of evidence to support that. And the feeling is if you've got a lot of rhinitis and don't treat the nasal symptoms, then you're not going to get on top of the nasobronchial reflex. So it's important to address that. And if you are using lower airway inhaled steroids, you get a cumulative effect. So that people are worried about using inhaled steroids for a variety of reasons. Some have a misconception that's the one that gives you breasts and makes you a bodybuilder. And of course the effect on growth and other problems like thrush orally and adrenal insufficiency as well at high doses. The importance we're looking at growth is that it does affect, if you look at collagen bone turnover, it does have an effect which lasts 6 months. But the reassuring thing about that is that children with asthma on inhaled steroids have obtained their final height, which is genetically predetermined.
Even though they remain on the steroids?
Even though they're on inhaled steroids, although they may obtain it 1 or 2 years later than their peers. The other important point to say is that if you don't treat asthma appropriately, then you have a chronic respiratory disease and you may end up shorter because you have had inappropriate treatment.
And what about I often hear it say that too high doses are used, even in adults and in children. What's the right dose? And do you add on the dose for the nasal cortisol?
Yes, it's all cumulative, and the dose is the lowest, the right dose is the lowest dose that controls their symptoms. And I think that every opportunity.
But this business in the past of going to the highest dose and titrating backwards has gone, hasn't it?
Yes. It's to start. The step 2 is to start low, and to
go slow.
And go slow. Absolutely. Absolutely right. I mean, the concerns, and the child has died as a result in Glasgow of being on an equivalent of 1,000 micrograms of fluticasone equivalent of inhaled steroids from adrenal insufficiency. And if you look above 800 micrograms of budesonide equivalent today, there's evidence of adrenal insufficiency, and we warn all our children on that sort of dose that they should carry around a letter saying if they get sick, they need oral steroid replacement, because it's having effects that we're not seeing, not measuring necessarily. So high dose inhaled steroids do have some
I think
problem.
you made the point that if you're on that dose, you really need to be seen by a specialist.
If you're on very high dose, absolutely.
It's a sign of a worrying sign. Let's go to our first case study. Emma is 12 years old. She's been coughing for 4 days. She comes to see you, Kerry, with her mother, who has a letter from Emma's school about her reluctance to have PE lessons. Although her mother hasn't noticed anything at home, Emma says that she coughs more than her friends and has difficulty keeping up with them. Emma's records show that she's had 5 courses of antibiotics for cough and upper respiratory tract infection in the past 2 years, always with a locum, Kerry, never with you. And during these episodes, she's mild wheezing and is breathless. She's often woken from sleep with coughing and occasional wheezing at night during these episodes. She describes the cough as dry. You're a patient, Kerry.
Okay, well, I don't think that we should just assume this is asthma without going further into the history.
But the coughing at night is pretty impressive, isn't it?
Well, the coughing at night, but the coughing can be from a number of reasons. The wheezing points more to asthma, but I'd certainly want to know what Emma actually means by the wheezing, because wheezing can mean different things to different people. And what Emma describes as wheezing or what her mother describes as wheezing might not be what we think is wheezing, sort of high-pitched noise coming from the airways in the lung. It could be coming from upper respiratory tract, it could be coming from nasal airways. I mean, I find from my experiences that a lot of people just cause any noise coming from the chest or nose as wheeze. The breathlessness, I think we need to take note of that, but once again, it might be breathlessness associated with normal exercise. So there's some things to tease out in that history a little bit more. I'd be interested to know in the family history. I'd be interested to know whether there's some history of atopic disease when she was younger, or whether there was any episodes of typical wheezing in infancy, toddlerhood, early childhood. And an examination at the moment. I mean, if I can hear a wheeze in that chest at the moment, then I'm going to feel more confident that this is wheeze. And at 12, I'd like to back that up with an objective measure of lung function.
So you do spirometry on
I
her?
do spirometry.
What else would you do on her?
Certainly think about doing skin prick testing, and if that spirometry was normal, think about provocation testing, depending on, I mean, it's available to me, but depending on whether it's available.
How did the school find out about this?
Her reluctance to participate in phys ed would be the first indicator that there needs to be some sort of GP consultation to try and find out what the underlying cause of that would be. And from that, we would expect, if asthma is the concern, that a written asthma action plan will then inform the school on the appropriate action to take. But a school
So you'd
involved.
expect the parents to come in from Kerry, should it be asthma, with a plan which they then hand to the school?
Yes. So as I said previously, the parents need to be the go-between between the medical specialist and the school, so that the right information is getting to the school and we're reacting in the right way. But there are protocols that override the individual situations. The 4x4 protocol, and the schools are well informed how to react to asthma, whether it's a first asthma attack that could be triggered by something that a child hasn't been exposed to previously, or part of regular control.
So Tracy, while we're still working out what's going on,
Yes.
is there a role for education in this child, or we just wait and see? It's only once they get the ticket, the label, asthma, that the practice nurse can kick in with some education.
I think if Kerry had gone through the consult with the parent and was satisfied with the physical examination, the clinical history, and wanted, say, a trial of Ventolin to be taken for when these symptoms arose again, then yeah, absolutely, there's a role for education. It may be more basic in terms of just going through some of the possible components of what to look for with asthma, what the medication is, how to use the device, and then when and if the diagnosis has been confirmed, then there would definitely be the need for some more in-depth education at that stage. But whether you're a community nurse, a nurse in the hospital, whether you're a practice nurse, actually any member of the healthcare team, we all have a responsibility to help educate these young people and children and their families, so they're able to treat appropriately until a diagnosis is confirmed.
Kerry, a general practitioner in South Australia asks what role peak flow meters have in the diagnosis, or indeed the ongoing management, even if you're not sure it's asthma.
I think peak flow monitoring has a limited role. I'd prefer a symptom diary under these circumstances. I think that's going to give me a lot more information. I think there are problems in, especially adolescents and younger children, doing peak flow monitoring. And so I think a symptom diary would be quite useful at this stage as well.
So do a chest x-ray, Adam, given that you're not sure what's going on here?
No, absolutely not. Trying to avoid them as much as possible in children. And I think the approach that Kerry's taken is absolutely the right one. To reinforce what she said, GPs are encouraged to do spirometry. Spirometry is a standard management in children who can do it, and it certainly replaced peak flow, which is very effort dependent and variable. So I think that we would encourage everyone with spirometry training to do it on children, but to hold off doing the chest x-ray just at the moment, as children's tissues are more sensitive to ionising radiation than adults.
So what are you going to do for Emma before you make the diagnosis here, or even if you've made the diagnosis?
Certainly at this stage, I think as needed, short-acting beta-2 agonists, salbutamol, terbutaline is most appropriate. Preventer therapy is not really indicated
Given even if it's asthma, it's down at the
even
mild
asthma,
persistent.
because at this stage she has
Mild intermittent.
she has intermittent asthma. It appears to be infrequent. And she's had 5. If those 5 episodes over the last 2 years were asthma, well, that certainly wouldn't meet the criteria for frequent intermittent asthma. So she's certainly not going to need preventer therapy at this stage. So I think as needed, short-acting beta-2 agonists, education around that. Bearing in mind that these children who have infrequent intermittent asthma can still have quite severe episodes at times and certainly can end up in hospital. So they still need the education, they still need the written asthma action plan.
So here's another question. In fact, a split question here. Some children are smoking younger and younger. What can be done about it? What's the role of the doctor or the asthma educator, Tracy?
Education.
It's all very well
key.
saying education. They don't listen to you.
No, well, I suppose.
Is there a shred of evidence that education makes any difference here? I thought there wasn't.
Absolutely. Oh no, there is. I think it depends on the way that you educate people and also in the way that you reach them as well. Some people are very affected by anti-smoking campaigns on the TV or by looking at lung cancer on a packet of cigarettes. Others, it doesn't do anything to them. When we're talking about teenagers, they could look at it and go, oh, that's gross, but hey, it's not going to stop me from doing it. I think persistence is the key with most things when it comes to medical education. It's about drumming through a consistent message, and that message needs to be the same in the hospitals, in the GP, in the community. If it differs, then people doubt, and especially adolescents will doubt what you're saying. If Kerry was to give one piece of advice, Adam was to give something else, etc., and then I was to say the complete opposite, then they wonder where the true source is. And I think these days we've got to take advantage of things like using the net and iPods and lots of other electronic types of equipment that we can get the right messages through. And certainly when you're looking through the internet, it's about getting onto the right sites and getting the right information up there.
Have you ever had to use nicotine replacement therapy, say in an adolescent, Kerry?
No, I've had no experience of NRT in an adolescent.
Right. Yeah. So the next question here is, given the publicity around the recent trial on breathing exercises, not quite the Buteyko but similar, just steady diaphragmatic breathing and the effectiveness of that, what's the role of that in children, if any? It seems to lower the use of reliever medications in randomised controlled trial.
Certainly some evidence to suggest that it may be helpful. And I think the important thing is that any child with asthma has to have a proper asthma management plan and seen by the GP or paediatrician and managed appropriately with appropriate medications.
So are you teaching them how to do the diaphragmatic breathing?
No, we don't at the hospital that I work at. But what we do is we look at what type of approach is going to suit the child and the parent, and also weigh up the evidence on both sides. But the main thing, as Adam was just saying, is around having your asthma action plan, is making sure that reliever medications are first line in asthma episodes and keeping in constant contact with your GP or your specialist.
So, but why not? If you've got a randomised, in fact this is better evidence you got from most of your other asthma treatment. There's very limited, my understanding is, for example, that most asthma trials in children go down to about the age of 12. You've got some, if you're lucky, that go down to the age of 5. You've got pretty flimsy evidence for a lot of asthma treatment in children, have you not?
Oh, we've got some pretty good evidence, Norman.
Yeah,
but you're right. One of the trials you're alluding to is one that's come out of the Woolcock, looking at breathing exercise, and I think
albeit in adults.
Yes, and I think that's right. And look, there are clinics around that teach Buteyko methods in children, and I suspect that we're out of our comfort zone and we don't know much more about it, and it becomes a personal preference whether we're happy to accept it as a complementary medicine, but please do what we tell you as well.
Let's go on to our next case study. That's Luke. Luke's 9, he's very active, he plays football, cricket, swims 3 or 4 times a week. He had allergic rhinitis and eczema as a baby and has had infrequent intermittent asthma since he was 6, and that's recently progressed so that he's getting quite much more frequent attacks. His GP suggests to his parents that his asthma would be better controlled with an inhaled corticosteroid. But Luke's parents are concerned about the side effects that they could have on Luke. Your patient, Kerry?
Well, I think the first thing is to acknowledge the parents' concerns about the steroids, not to just brush them aside, because they've probably already done a search on the internet for steroids.
They're way ahead of you.
They're way ahead to start with. They've probably read the evidence that that the growth velocity may be slowed, and the other side effects that we talk about with steroids. But I think our job then is to talk about that when we use steroids at appropriate doses, that those side effects are not significant, okay? And to really have the open discussion about that. There's also alternatives to inhaled steroids, and the other thing is making almost like a
such
deal
as the
with
leukotriene,
them, such as the leukotriene for mild persistent asthma. And the other thing is making a deal with them that when, if we're following guideline management, we're going to be reviewing this child regularly, that when their asthma is controlled and it's been controlled for a certain period of time and lung function is normal, which, we may be able to do lung function on this 9-year-old boy, we can do a trial off inhaled steroids. And being open to that. It also encourages them to come back for review.
Do you get many questions being asked in the pharmacy when you're dispensing?
We do get asked questions, especially about the dangers of taking steroids in children. And I think it's important that the pharmacist, like Kerry was suggesting, acknowledges the parent's concern, acknowledging that there potentially may be an issue, but the dose that they use is kept to a minimum. And regular review by your doctor is the really important thing. I guess the side effect we see the most often in pharmacy is the oral issue with not only children is not washing their mouth out after they've had their
not using spacers.
Inhalers. Yeah. So.
In fact, what we've got, is a video from the National Asthma Campaign and National Asthma Council showing the correct use of the spacer device.
Hello, Mandy. I'm just wondering if you could show me how you use your puffer and spacer for me. That was really great. Thank you very, very much.
So that's from the National Asthma Council. Tell me about the safety of leukotriene receptor antagonists. They haven't been around as long. It took many years for things like the Blue Mountains Eye study to show the relationship between cataracts and the old doses here, and we've got leukotriene receptor antagonists. Are we sure that they're safe in children?
They've been around for quite a few years, and obviously, like all newish medications, there's ongoing surveillance and people reporting any potential side effects. The sort of side effects that we see, if we were to see any, would be sometimes behavioural disturbance or headaches or problems sleeping at night. In fact, the FDA recently looked at some reports of suicides in adults with montelukast. So there's clearly ongoing surveillance, and the report has recently been updated by the FDA saying they can't find an association with it. So clearly there's ongoing surveillance, but generally, certainly in my practice, it's extremely safe, and very occasionally I've had to stop children because of behavioural sleep problems.
So what are you going to do for Luke?
Well, we're saying Luke has mild persistent asthma. His parents are concerned about inhaled corticosteroids, even though we may have had that discussion with them about asthma being an inflammatory disorder. We'd really like to, inhaled corticosteroids are an option. But I think we could give the choice of low-dose inhaled steroids or montelukast. So I'd be keen to give him a trial of montelukast to start with for mild persistent asthma, especially when he has a significant exercise component as a trigger.
And what would the asthma action plan start to look like, Tracy?
Well, it would start to form into certainly reinforcing about use of the preventer medication. If it was the Montelukast that Luke was to go on to, then that would be taken once a day. And the asthma action plan starts to look like when well, when not well, and when your symptoms get worse. So it's about reinforcing the use of your regular preventer medication, but also looking at the reliever medication in terms of how much you need according to the signs and symptoms. But the asthma action plan is a very fundamental part of management in helping for those basic concepts to be reinforced in when you take your medication, how often you need to take it, and when you need to seek medical advice.
And presumably there's got to be a wide range of adjustment in the education depending on the age of the child.
Oh, absolutely. You do. You need to tailor.
Status.
Yeah, definitely. You need to tailor your education to their age, to their developmental abilities, and to certainly the needs of not just the child but also the family as well.
Another question: is swimming still encouraged for asthma? Does it make any difference?
Yes, well, you've touched on a thorny issue actually, because there's been recent work coming out of Belgium suggesting that if you swim, you're more at risk of developing asthma. So there's been a lot of work going into this, and it's raised a few eyebrows, because clearly in Australia children drown. There's a lot of water about, and swimming is extremely important. It's something that children shouldn't be discouraged from. However, because of the volatile substances, particularly the chlorine, it can be toxic, and people have looked into athletes' exhaled breath condensate. We can actually measure stuff that's coming out. So clearly, if you're going to choose swimming, then an outdoor saltwater pool it's got to be the best. Indoor saltwater pool the next, and then an indoor chlorinated pool. So we would encourage it.
So presumably it's the same advice. You take a couple of puffs of your reliever before you jump in the water.
Absolutely, and I think the advice that we're given is not enough evidence to discourage swimming. It's an extremely important exercise. There's evidence to suggest it improves asthma in many children. Children enjoy it. It's exercise, but there's some controversy that is emerging, particularly, as I say, from the Belgian group.
So, Kerry, a question. I mean, it used to be true that we had amongst the world's highest rates of asthma, but that's not so true anymore. The question is, do we still have internationally high rates of asthma?
We still have relatively high rates. I still think we rank sort of 4th or 5th at least, and we, certainly we have a prevalence of around about 11% of school-aged children with asthma. So that's still significantly high, but it's not the 20 to 25% that figures that were quoted, 10 to 15 years ago. And there's a myriad of reasons for that.
Well, another question here, actually, I think we've really covered that, but how do we handle the concerns that people might have about combination therapy with long-acting beta agonists when they've seen stuff on television that they're dangerous? But we've already, I think, answered that you shouldn't really be using them very much at all in children.
I think that's right. There's a huge growth, and if anything, a very small percentage of children should be on it, perhaps less than 5%. And the evidence, unfortunately, is way against it, that people are not listening to guidelines, they're not adhering to them, and the growth in the combination therapy industry is skyrocketing. And really, people should be looking at their practice if that is their current practice.
So 1 year has passed in the life of little Luke, and he presents back to Kerry with his mild persistent asthma, but he's recently noticed that there's an increase in his symptoms, that he's getting them almost daily now. And in terms of the sports activities, he's regularly having to come off the field to manage his symptoms, or just heavy symptoms. And he's now classified, I suppose, as moderate persistent asthma?
Yes, the classification would be moderate persistent asthma if he's getting daily symptoms, or even severe persistent asthma with daily symptoms. But I think it's really important to find out whether Luke has been taking his medication, and whether that's been, if he's not been on his preventer medication, whether that's been the cause of his breakthrough symptoms. Checking his inhaler technique. I mean, a lot of these children don't like using spacers if they have been prescribed a puffer with a spacer. So looking at those sorts of things before we just assume that his classification of his asthma has changed.
And is that sort of approach you take in the pharmacy if they come in complaining to the pharmacist?
One of the things that we do in the pharmacy, I suppose, is very much about checking inhaler technique, checking what inhalers they're using, as in whether they're using their reliever or their preventer. I've had many situations where we've had children using their preventers rather than their relievers because they've got confused, and also making sure that they're using their spacers appropriately, and looking after their spacers. That's the other thing. We do see a lot of broken spacers that the valves aren't working on and things like that because they haven't been replaced.
While Kerry's thinking hard about what she's going to do about Luke, what are the instructions you give teachers about exercise-induced asthma?
First thing we alert teachers to is that it is a major cause of asthma, and to be alert for that, that it can occur during and after exercise. The written asthma action plan, as we've said several times tonight, is just a really fundamental and important document to inform the school on the individual needs. But exercise is a trigger for asthma that is not to be avoided. It's better to be managed so that the health benefits of all sorts of exercise can be gained by all young people. We provide some information about what to do before, during and after asthma.
So what did you say before?
Before asthma, before exercise, the critical thing for a young person to do is to take their reliever medication or other recommended medication. That's usually about 5 to 10 minutes before they would warm up and ease themselves into exercise and sport. During sport...
Is there any evidence that warm-up makes a slight bit of difference?
I would
People
say
love
that
warm-up and stretching, but does it make any difference to the child with asthma?
I think the fact that we're giving the airways a chance to get themselves ready and used to the fact that we're going
Limbering
to be
up the
putting
airways.
Yes, it's that sort of thing. So anecdotally, yes, we do know that it's going to prepare the young person a little bit better for what's coming.
So what about during exercise?
During exercise, watching for symptoms is the important thing, and if there are asthma symptoms that do occur, for either follow the asthma action plan or the 4x4x4 protocol, so that the young person's asthma symptoms could subside, and if they do, they can return to the activity. The really important message is if the asthma does reoccur again, you continue to treat that asthma, but you do not allow them to return back. It's the alert that there is something wrong at that particular point in time. And one thing that a lot of people don't understand is that exercise-induced asthma is quite common after exercise has ceased, and for teachers to be alert for that as well.
So you've got a protocol for after too. So what are you going to do for young Luke?
Well, young Luke, depends on what he's already on. If he's been adherent to his medication and his technique's good, now he may have been on montelukast, on the leukotriene receptor antagonist. And so if he was on a leukotriene receptor antagonist, then the next step would be to introduce inhaled corticosteroids. Once again,
take him off the montelukast and put him on?
Take him off the montelukast, put him on some low-dose inhaled steroids. We have a choice of 4 inhaled steroids in Australia, all very good. Once again, it comes down to a discussion about which sort of inhaler device would suit Luke, and whether we want to use once a day or twice a day medication.
Why would you take him off when they have different mechanisms and presumably they could work together?
Our hands are really tied by PBS regulations that we can't have him on we can't prescribe a second preventer.
So if they could afford a private script, it would be all right?
Afford a private script, that's fine, or we might...
What's the evidence here, Adam?
Well, the two working together. There's some evidence to suggest that two of them work together.
And does the leukotriene receptor antagonist act as a steroid sparer?
It doesn't act in that way when you have the two together. Certainly, there's some work recently in New England Journal of Medicine that children on montelukast can come off effectively straight onto inhaled steroid. The other way around, inhaled steroid can go onto montelukast without tailing off the inhaled steroid. So they're obviously working by different mechanisms, but the PBS here it does influence the way that we prescribe. But if a child doesn't respond to montelukast, it's unlikely that they're going to respond in combination to inhaled steroids. So it would be sensible to stop it if they haven't responded clinically.
So what happens if he's been on inhaled corticosteroids at a modest dose, not working? Just take us through your thinking about how you escalate dose.
Well, one would hope that he'd just been on a low-dose inhaled steroid. And once again, after checking adherence and inhaler technique, the next step is really to just push those inhaled steroids up just a little bit more. Okay, we don't want to be using high doses. We don't want to be tempted to use high doses. But just say going from budesonide, he might have been on say 400 micrograms a day, maybe pushing that up to 600 micrograms a day. With fluticasone, he might have been on 2 puffs twice a day of a 50 microgram one, just maybe going up to 250 micrograms a day, 125 twice a day. And we do now have an indication for children with seclenicide, and the advantages of that is it's once a day. Even though the PI would say that you don't have to use it with a spacer, I think most of us would prefer that it's used with a spacer. The advantages of something like seclenicide is that it, the once a day dosage, that it doesn't actually become an active drug until it gets down into the lung tissue, so you don't have those problems with the oropharyngeal side effects such as dysphonia, potentially oral thrush. But if we're using low doses, we shouldn't be getting those sorts of side effects anyway.
And if we come back to the comment made at the beginning, once you're getting up to that sort of level, if it's not working, this is an indication for referral.
I agree. I think rather than pushing up a higher dose of steroids, think of referral to a local paediatrician or and then beyond that, respiratory paediatrician.
And presumably you want to know if he's got rhinitis, because that could significantly affect his asthma.
I think controlling his allergic rhinitis, and I think when we first heard Luke's clinical presentation, he did have allergic rhinitis, so controlling his hay fever would be really good. That's why it would be nice to be able to keep him on the leukotriene receptor antagonists. We may be able to do a little bit of a crossover with that, and parents may be quite willing to purchase montelukast privately as an alternative to nasal steroids or antihistamines, which are actually not that good to treat nasal congestion anyway.
One little trick, if I may, just that with inhaled steroids, is if you inhale, it's quite tricky to learn, but if you can get the child to do it, inhale the steroid and exhale through the nose, you can get nasal deposition.
Waste not, want not.
Absolutely.
Bit of sort of green recycling.
Correct.
Oh, I shouldn't have said that. Should I? No, sorry, forget that I said that.
And you get nasal deposition, which is a good way of monitoring how much inhaled steroids you're using.
Well, they're watching so much smoking in the movies that they probably know how to do it already.
Correct.
And some of us are old enough to remember when the specialists used to put the asthma steroids up the nose.
Nice.
Yeah.
And the educational, asthma action plan type implications here for Luke in this situation?
Oh yeah, again, absolutely.
So it's getting volatile. I mean, we've got to get this under control.
Yes. Yeah.
So it's not necessarily an asthma action plan for the next year. You're wanting to review this regularly.
Oh, definitely. If you're going to be moved up in terms from something like montelukast through to an inhaled steroid, you'd want the reviews to be more regular.
How
and because
regular?
of, well, maybe every 3 to 6 months, depending on what happens. I mean, if he has a hospital admission, especially if he needs to be admitted to an intensive care unit, you'd want the reviews to maybe come every 6 weeks until things are well and truly under control. And I think at the age of 9, hopefully he's old enough to understand about his own asthma and about how to help with managing it with mum and dad. So it's done as a team. It's not like we want Luke to take all the responsibility for it, but the fact is he's at school, going to camps, possibly staying at a mate's place. So the education needs to be tailored to his needs at this point, especially if you are dealing with underlying adherence problems.
So is this doctor review, Kerry, or are you happy for your practice nurse to do the review?
I'd be happy for a practice nurse review. I think if GPs have got appropriately trained practice nurses in their practice, they don't have to be fully qualified asthma nurse educators, but I think they do obviously need to have a certain level of training and understanding to assist GPs. I'd certainly want to be reviewing Luke within a few weeks of a change of therapy.
Yeah, 3 months feels long.
I think a review within a few weeks is most appropriate for any change of therapy for anything.
Can I add in, sorry Norma, can I add in spirometry as well, just to echo what they say, it's very important. Some children will think they've got normal lung function and they run a spirometry 75% and they've learned to adjust to that. So without objective evidence, it's really important every time they see the GP or the paediatrician to have the spirometry.
So they get that feedback and the GP gets
Absolutely,
feedback.
and they get a shock.
And I think doing that objective measurement, we find in my practice where we do lots of spirometry, that the fact that you're going to measure something when they come back is another hook into that regular review, just like people expect to have their blood pressure measured.
Luke's at school a few weeks later taking part in a football match, and he comes off the field distressed and anxious. He can't get a sentence out, his pulse is up, and when you see him carrying the surgery, he's got moderately loud wheeze throughout the chest. and he tells you that he's been using his puffer frequently today and it's not really helping.
Well, I'd be quite concerned about Luke at this stage. I'd have all guns firing. I'd have the oxygen there ready to give him. He's got a moderate to severe exacerbation which needs to be managed efficiently and quickly and assessed regularly. He needs to be monitored there and then.
So we'll just hold the thought for a moment. What does your guidelines say that the teacher should be doing in this situation when he's pretty sick on the field?
The 4x4x4 protocol at this point in time.
So this is asthma first aid we're talking about?
Yeah, that asthma first aid protocol would be alerting the teacher that they've moved into an area of concern about the young person's condition and they should be phoning an ambulance at that point in time. So we're really firmly in step 4 now.
But they should be given an inhaler.
And while we're waiting for an ambulance response, we continue the 4x4 treatment.
So in the surgery, just tell us what you do.
In the surgery, he would be given oxygen and we would be giving him 12 puffs of salbutamol via a spacer. We'd be assessing the clinical response to that, 5 to 10 minutes later.
So just on this 12 puffs, is it 2 puffs at a time in the spacer or 12 into the spacer and you just keep on breathing it in and out?
Just 1 puff and 3 or 4 tidal breaths will empty a large
just like
body
the one
of
we
spacer.
saw and then another one?
Yep. And repeating that 12 times. We don't need to be using nebulizers. We've had a problem with nebulizers or air pumps in the past and the actual nebulizer bowls not being kept up to date and being dirty and not nebulizing as they should be. So we know that 12 puffs are the equivalent of the old 5 milligrams of salbutamol in a nebule. So we can give that. It can be given quickly, it can be given efficiently, it can be given easily.
Even to quite a distressed child?
Even to a distressed child. And
how long do you wait to see if there's an improvement?
Short-acting beta-2 agonists work very quickly, so they're going to start to work within a few minutes, get to their peak effect maybe anywhere between 10 and 20 minutes. So I'd be assessing this child at about anywhere between 10 and 20 minutes, depending on how worried I was about him, and I'd expect some clearing of that airway obstruction, listening to it, and giving another 12 puffs at 20 minutes. I'd be thinking about, do I need to transfer this child to hospital? In a rural and remote area, it might be that I am the hospital, so I have to deal with this. But
what about oral steroids?
And I'd be also considering giving him some oral steroids, 50 milligrams of prednisolone, because I think I'd rather give that sooner than later. I mean, this is a moderate to severe exacerbation. It's going to need treatment with oral steroids anyway.
What do you think?
Absolutely, couldn't agree more. And just a word of warning is that, of course, you can get paradoxically worse with a beta agonist as you bronchodilate, and it increases your ventilation perfusion mismatch. And there have been unfortunate cases of children dying in the GP surgery, particularly if there wasn't any oxygen around. So I think people just have to be aware that you can actually be made worse with.
So oxygen abolishes that risk?
It probably doesn't, but it treats hypoxia. So if you're going to die because of hypoxia, then having oxygen there will certainly.
So how scared should GPs be? I mean, that puts the fear of God into me. If I was a GP,
yeah.
I shouldn't be treating children with acute exacerbations.
Well, I think you've got to be cautious. I mean, asthma kills, thankfully very rarely, and particularly when you're unwell, I think you've got to understand what you're doing, and if you're going to treat using beta agonists, realise that you can increase mismatching.
So essentially, your essential thing here is that you assess the severity, how hypoxic is the child, how distressed, what's the pulse, etc., etc.
You've got a saturation monitor, fantastic oxygen nearby, and do exactly what Kerry's been doing. And
have a short fuse for referral,
Absolutely.
but it might be difficult in a country town.
Absolutely.
And I think with GPs not relying necessarily on oximetry if they are using oximetry without actually looking at the patient as well. I think there is a bit of a problem out there in some environments of saying, oh, well, the figure's okay, but not actually looking at the child.
To what extent do you find that people in the acute situation forget they've got an asthma plan?
Oh, absolutely. Yeah, it's very common. Yeah, they could have the plan on the fridge at home. Mum and Dad could know it by heart and memorise it, but when their child is having an asthma episode in the middle of the night, it's 3 o'clock in the morning, you've got other kids to get to school, all those other factors, it can go completely out the window. And they would think back to something that happened with Kerry, something that happened at the hospital. Oh, I can give it every 20 minutes, and maybe my child will turn that corner, and maybe they will. but certainly it's a dangerous situation to be in at home. So I think if the one thing that parents can keep in the back of their mind is if they need to give the Ventolin more than every 3 hours, they need to seek medical advice straight away.
Isn't the asthma action plan really quite a sort of middle class phenomenon? It's great, in a kid that comes from Toorak or the wealthier side of town. But if you're in a family where there are lots of kids, where a woman is struggling to look after all these kids by herself on a pension, there's smoking around. There's just too many other things in that woman's day to really focus on an asthma action plan. It's a luxury she can't afford.
Well, I think that's when you've got to take the opportunity to sit down and engage with that parent and try to find out what you can do to really help them. Maybe suggest.
But you can't be there at 1 a.m.
No, absolutely not. But I mean, I think there's certain things that's in our circle of control. There are things that we can't influence, and that might be that situation at 1 o'clock in the morning where all 6 kids are screaming and other things are going on. But if you can try to instill the best as we can in parents that if your child needs X amount of Ventolin, depending on their age and what their needs are, they need it more than every 3 hours, the best thing that they can do for their child is to seek medical advice straight away.
And do you have much experience of treating Aboriginal children, particularly in the city at Westmead?
No, we actually, in the area that I work in, Durrock takes very good care of the Aboriginal children that are there, so I haven't had a lot of exposure.
So really Aboriginal health
children.
workers and
absolutely,
and community helps out there.
Absolutely, they do a great job.
So after this acute exacerbation, are you going to change his regular therapy?
I'm going to bring Luke back for a review very quickly, probably within
tomorrow?
the next few days. Yeah, for sure. And I'm going to be keeping a very close eye on him over the next few weeks before I let him go back to sort of routine 3-monthly review. And it's going back through the standard, has he been taking his medication? Has he been taking it correctly? Do we have the correct diagnosis? And seeing what actually triggered, looking at why he got worse. Yeah. And, he may have had a viral upper respiratory tract infection, which was the aggravating factor under these circumstances.
So one of the messages I'm getting is that when things change like this in a child with wheezing, you go back to first principles and you start all over again. Is there something you've missed here? Thank you all very much. Fascinating program. What are your takeaway messages for those watching?
There is an asthma-friendly schools program. It's a mature program. Most schools around Australia are re-engaging with the program through a re-recognition process, so it's fairly well entrenched in that sense. It provides for written asthma action plans as the fundamental go-between between the GPs and the school, and providing good individual care of asthma and also preventative care of asthma overall. It will train the teachers and will set up good management practices in schools, and it's well accepted in the school systems around Australia.
Tony Riley?
I think for the take-home message for pharmacists is make sure that your patients know their medicines, know how they're meant to be using them, and make sure they understand which is which, which is a reliever, which is a preventer. But the other thing, I think pharmacists have a unique opportunity, because we possibly see these patients more than any other health professional, is to remind especially the parents of the importance of regular review.
Tracy?
Take-home message would be that education and management go hand in hand, and that you need to tailor the education to suit the child and the parents and the family, and that whether it's with the pharmacist, whether it's with the GP, whether it's with the specialist, with an asthma educator in the community, it's about us all being consistent, being able to follow the guidelines and making sure that we're clear and concise in the information that we're giving.
Kerry?
I think making the correct diagnosis is really important. Taking a good clinical history, which will then follow through to the appropriate classification of the asthma, which will then lead to the appropriate pharmacotherapy, so that we don't have under-treatment, we don't have over-treatment, and the regular review.
And don't throw around the combos.
Yeah.
Absolutely. Don't turn around the combos. Watch your use of long-acting beta agonists, and make every opportunity an opportunity to use spirometry. And of course, the evil weed smoking, really address that at every opportunity possible.
Thank you all very much indeed. And I hope you've enjoyed tonight's programme on managing asthma in primary school children. If you're interested in obtaining more information about the issues raised, there are a number of resources available on the Rural Health Education Foundation's website, and that's at rhef.com.au. Don't forget to complete and send in your evaluation forms and register for CPD points by completing the attendance sheet. Thanks to the National Asthma Council for sponsoring this programme with help from the Australian Government's Department of Health and Ageing. But thanks to you for taking the time to attend and contribute. I'm Norman Swan. Bye for now.